One of the things that obviously GIST Cancer UK has always focused on is supporting patients and raising awareness. And those things, this is in the general population, because I think even now, when people are diagnosed, quite often when they go to see their GP, the GP, it's the first patient they'll have come across with this cancer. And most people, when you tell them what you've been diagnosed with, they haven't heard of it before. So there's still a very strong need to raise awareness of this rare cancer. But I think over the years we've made some inroads into that. And it was our good fortune some years ago that we went to a conference and presented our stand, and we were there to offer leaflets, etc., to patients. And what we didn't realise is that in that audience of patients, there was one patient who worked for a very famous sort of organisation, and she came up to us afterwards and said, I'm actually a senior person with UK TV. I'm also a GIST patient, and I'd like to put your charity forward for being one of our partners, a charity partner for the next year. I think they had 11 or so charities that were submitted by the employees of the organisation, but her submission on our behalf actually won the largest number of votes. And they raised a lot of money for us to help us open up things like the tissue bank and be able to support those initiatives that we had underway. And then at the end of our term with them, they asked us if there was anything else they could possibly do to help. They said, we've got all these skills. So I asked them if they would be able to help us make a video to try and help raise awareness. And obviously there's various things you need. Obviously they have great technical skills when it comes to filmmaking, but we also needed people who could advise and be willing to be filmed. And key to this, because the target audience are primary carers and GPs, was that we found a GP who was willing to work with us. And our first attempts at that didn't work. I think Judith's GP said she'd like to help, and then unfortunately overloaded with work, she couldn't help. So a bit at a loss of how to take this forward. I was walking one of my numerous dogs and bumped into one of my neighbours who is a GP. She was just qualified, and she said she'd ask around. Now I live in Bristol, or just outside Bristol, and she managed to make contact with a lead GP in Gloucester. And she said she'd be able to help. And that lady is Dr. Sadaf Haque, who hopefully you'll see on this screen in a minute. But amazingly, when I explained to Dr. Haque what we were trying to do, she then revealed that she'd actually trained in oncology at the Marsden and was the sarcoma lead for the Gloucester area. So it was just a very fortuitous meeting. I couldn't have planned it better, really. And she trained with Professor Robin Jones. I think she trained under Professor Ian Judson and along with Charlotte Benson, etc. So it was our very good fortune for that to happen. And we spent a very long time putting this film together, but then COVID came and everything kind of stopped. So that's why there's been more of a delay in getting this out to general public than we would have normally anticipated. So, hello Sadaf, can you hear me?
Hi there, yeah, my name is Dr. Sadaf Haque. I am a GP in Gloucester, and I also work as the clinical lead for cancer for Gloucestershire CCG, which is soon to become One Gloucestershire ICS.
So Sadaf, I've explained the sort of preamble and the history to what we've been going through for the past few years to get this film ready, and I've explained how you and I made contact via my next door neighbour, and it was a very fortuitous meeting. So we're going to play the first part of the video in a second, but I just wondered if you'd like to address the audience with your perspective on things.
Well, I'm really delighted to have been part of making this video with GIST, and really sorry that I couldn't be with you today in Bath. Yeah, I hope you'd enjoy watching the video. The message really I wanted to get across is, the primary care is here, is ready to kind of hear what symptoms you've got. Don't sit on symptoms. If you're worried about anything, just contact your GP practice. Part of the delay has been this horrible pandemic, and it's set a lot of cancer diagnoses back a lot, and broadened the health inequalities. So people who were reluctant to contact us or were unable to before, they were put off by COVID, and now the recovery phase we're in to try and encourage people to come back into primary care. So everyone's got different experiences themselves, and I really don't want past experiences of that haven't been quite right with your GP, just to keep coming back and pushing on the door. I hope that this message is not something that is diagnosed necessarily in primary care. It is a secondary care hospital diagnosis, usually a biopsy-proven diagnosis, but actually the symptoms are the same, that we would want to be referring for investigations, for endoscopy, or for scanning at the very basic level, blood tests, etc. So we need to start the journey together with your primary care doctor, and we don't want these cancers to be diagnosed in accident emergency. So I'm a GP in Gloucester. As Jayne said, I've worked with the two clinicians that we're going to see on the video, the three actually within Judson as well. I actually went to medical school with Professor Jones, and I was an oncology registrar at Marsden before I rejoined.
Recording in progress.
As a GP in the Cotswolds, but then I've kept my love of oncology and passion to get cancer pathways right. So I'm now working as the clinical lead for cancer in Gloucestershire, CCG, soon to become the One Gloucestershire ICS. So I've done a lot of national work with Macmillan, with Cancer Research UK, and just really passionate about getting this right for people. So I'm here sort of with the primary care hat on. So any feedback or questions that you have after the video, I'm really happy to take them. And I think it's a good video, and I hope it makes sense. And we're wanting to share it so that as many of my GP colleagues will see it as well. So we're having it up on various education platforms. Is that all right, Jayne?
That's great. Thank you very much. Now, so I've just got to see if I'm going to be able to, get this going. So hopefully, now to begin with, the video's quiet because you're supposed to be the GP and you're supposed to be reading what's on the screen. So this is their education session, the first part.
Thank you all so much for joining us this afternoon and for giving up your time to help my GP colleagues learn a little bit more about gastrointestinal stromal tumours. A bit of a mouthful.
Welcome to Satvinder Midan. You're an upper GI cancer surgeon, formerly at the Royal Marsden and St George's Hospitals, and now based at the London Clinic.
Charlotte Benson, welcome. You're a consultant oncologist.
That's right.
At the Marsden, specialising in sarcoma, and you work alongside Robin Jones, who's also a consultant oncologist. Sarcoma. There are two types, aren't there? There's bone sarcomas and soft tissue sarcomas. Is that right? So, Charlotte, where does GIST come in?
So GIST falls into the soft tissue sarcoma category, right. And it can arise anywhere in the gastrointestinal tract. And they represent about 30% of all gastrointestinal sarcomas. And what's important is that they can affect children, adolescents and adults.
Okay.
GIST, or gastrointestinal stromal tumour, is a type of soft tissue sarcoma. There are more than 50 different sorts, but this is actually one of the commonest. In fact, we think it's the commonest sort, approaching 30% of all cases. The most reliable figures we have for the incidence of the disease gives a number of 11 cases per million per year. So that would give us about 680 cases or something like that for the whole of the UK. So it's not a common disease, but nevertheless, it's an important one.
The symptoms of GIST are often quite vague and might be persistent anemia or abdominal symptoms or indigestion.
And that overlaps with quite a few other things that we see in our day-to-day practice as well, which we'll come back to a bit later on. But Satvinder, why is it important to diagnose GIST tumours early?
I think the importance of diagnosing GIST early, as with a lot of other cancers, is that frequently surgery alone is going to be sufficient to achieve cure for the patient. So there's no requirement for further treatments, and that's an important thing.
Okay, so that would be better for the patient's outcomes and for their experience
For sure,
to have their cancer diagnosed earlier. So what sort of symptoms, Charlotte mentioned a few, but from your point of view, could you advise us about, I'm particularly concerned about dyspepsia.
Yeah.
So we have a lot of people that don't fulfil the 2-week wait criteria for direct access endoscopy. How would we manage somebody who comes into us with dyspepsia? Do we give them a course of antacids and...
Well, I think, you're right. These are common symptoms in any general practice. And I think it's the persistence of symptoms that probably is the important thing, and whether there are associated symptoms such as weight loss. So I agree, a lot of these patients with early disease are not going to have the emergency criteria for 2-week assessment. I think that's right. And there needs to almost be a different pathway to look at those patients. So the symptoms of stromal tumour may be mixed in with other tumours, gastric cancer, pancreatic cancer, a variety of other things in their early stages before you see the late symptoms. And I think it's the persistence of those symptoms, and especially in somebody perhaps who doesn't normally attend the GP surgery because he's very well and then comes suddenly with persisting symptoms. I think that's
a red flag for us.
I think so. That's the kind of patient that I'd be anxious about. So the majority of certainly stromal tumours are going to present with those kind of vague symptoms, and the patient then go into an investigation pathway and be found to have probably a stromal tumour in the stomach. But you're right, the symptoms may well overlap with a variety of other, both cancer and non-cancer diagnoses.
IBS, ovarian cancer.
Absolutely.
That's the big one that we know as GPs is incredibly hard to diagnose. So I know that you all work at a tertiary referral centre for GIST tumours. Are there other centres around the country? Is it somewhere that we should be sending our patients to?
Yes, there are other tertiary specialist centres around the country. I think it's really important that patients with these tumours, these rare tumours, are managed by specialist teams. It can be very difficult to make the diagnosis, and it's important.
Need a specialist pathologist.
Correct, absolutely.
Okay. And radiologist and
in time, multidisciplinary.
And to actually manage, so that's where you would come in as oncologist to decide with the post-surgery whether a patient needs treatment. We'll come on to that in a moment, but I think I would guess as a GP with all the vague symptoms, it's important for me to think that this could be something more sinister, and to be aware of the possibility of GIST tumours and to refer in for a diagnostic or more diagnostics if the pathway allows it to happen all in secondary care. That would be the best thing for primary care. But what would be the expectation from your end? How would the patient arrive at a specialist centre? Just so that we can help inform our patients of what might happen.
Well, I think from the entry point, it depends on whether the presentation is as an emergency or an elective diagnosis. That's probably the first thing. And the likelihood is, because of the nature of the symptoms, gastrointestinal tract, the majority of these patients are going to come through the surgeons or the gastroenterologist. So, for example, for me, the patient may have had an operation already in his local hospital if he presented with an emergency, such as a bowel obstruction, because plainly you've got to get on with that. So that the local surgeons would have dealt with the acute situation and then refer up to someone like me and say, okay, well, look, please can you take the patient on, discuss at your meeting, and at that point primarily to decide whether additional treatments on top of the surgery are going to be valid or important for that particular patient. So that's really the emergency presentation.
Okay.
An elective presentation where, for example, you may send a patient of yours with perhaps a little bit of dyspepsia and anemia, let's say, to have an endoscopy, at which they, the gastroenterologist carries out the endoscopy and he sees the very classical submucous tumour in the stomach, which I always think looks like a little sort of potato hanging off the wall of the stomach. And they say, oh, well, this is a stromal tumour, and then may send to the surgeon, but in an elective way. And then we would work that patient up from there. And the decision-making process might include perhaps not surgery. Maybe we would look at treatments other than surgery, or whether the surgery would be by an open operation if it's a very big tumour, or whether the surgery would be by, more and more these days, more likely to be by some form of keyhole surgery to minimise the impact.
So it's quite a complex, complicated MDT discussion. So where would you, Robin, and you, Charlotte, come in to this point in the patient's pathway? What patients do you offer ongoing treatment?
Well, we're often very interested in the radiology, so we'll look at the CT scan. Sometimes GIST can also be an incidental finding on a CT scan, and then we'll have an in-depth discussion with the surgeons about whether they should proceed primarily to surgery, or if it's a large tumour, sometimes we think about whether we can offer a treatment to possibly make surgery a little bit easier. We also, in our MDT, will discuss with our pathologists. So if it's after the fact and they've already had a biopsy or surgery, we can look at certain aspects of the pathology to try and predict what the behaviour of the GIST might be in the future.
You mentioned a treatment. What could you tell us a little bit about the treatment and what our patients might expect from it?
Well, the majority of GISTs are driven by a mutation in a gene called KIT, and there's a drug called imatinib, or Gleevec is the trade name, which is a very effective treatment for the management of GIST. It was first developed for patients with metastatic GIST, but more recently has also been brought forward into the treatment pathway and sometimes might be used preoperatively in patients with a large GIST, which needs to be decreased in size prior to surgery.
It's a small molecule, not chemotherapy. It's not an antibody, and it inhibits a protein called KIT, K-I-T, which is normally in this disease permanently switched on because of a mutation in the KIT gene. The benefit of giving patients preoperative imatinib is not only does it shrink the tumour and may then result in the patient not requiring a total gastrectomy, or in the case of a rectal GIST, an AP resection and permanent colostomy, but also at the time of surgery, the tumour is no longer metabolically active, it's quiescent, having responded to therapy, and there's much less risk of intra-abdominal dissemination at the time of surgery.
What's the prognosis, Robin, of patients with these type of tumours?
So, as Satvinder mentioned, the majority of patients can be cured with surgery alone, but there are patients with tumours that have high risk of recurrent disease, and those are the patients that we would select for post-operative treatment with imatinib.
And is that how is that given? Is that an infusion?
So that's a tablet medication that's taken every day.
Okay.
And for a cancer treatment is relatively well tolerated, but inevitably does have some side effects, but in general people tolerate it very well.
So what are the side effects that we
it
should
can
be aware
include
of?
nausea, vomiting, fatigue, puffy eyes, some laboratory blood test abnormalities, but in general, as I say, very well tolerated drug.
And is your compliance good?
I suppose compliance can be a difficult thing to monitor and document, but in general, yes, I would say that compliance is good.
Some patient stories that we're going to hear at the end of this module talk about being able to work full-time whilst being on treatment. And is that more the norm with this type of tumour?
Yes, but most of our patients do manage to maintain a good quality of life and continue to work while on treatment.
That sounds very positive.
It is positive.
Would you recommend that we could offer in partnership or signpost our patients to? So we, Professor Ian Judson, who is also talking on this video,
leads the medical advisory board at Just Support UK.
He originally did the earliest trials with GIST tumours. Is this a go-to resource for our patients?
Yes, it's a fantastic resource for patients because the disease is rare. Very few people have actually heard of it, and it's great for patients to be able to talk to other people who have experience of the disease and
they can get in touch with the charity and have links. And also Macmillan and CR UK, I know, have got some pages specifically about GIST tumours for patients and GPs. To look at, so that would also be very helpful.
It's interesting that you mentioned about compliance. I think one of the real advantages we have at specialist centres is we've got clinical nurse specialists, and these are nurse experts, and they really know about the management of side effects of these treatments, and they're always a very good point of contact for our patients and are available by phone, and I think that can be really helpful in signposting patients.
Agreed.
And the Just Support UK charity you mentioned also, as well as written information, they have patient forums, so patients are advising each other, and that's also
that peer support is really valuable.
Helpful,
yes, especially for a tumour that's rare, but can have some devastating consequences on your life. I was mindful that the patients that are on our story at the end of the video are quite young, and is that something that is because we know that cancer's on the increase because we have an ageing population, but is the incidence of patients diagnosed with GIST, has it stayed at sort of similar age group, or is that also rising in older people?
I think it's difficult to say. I think originally it looked like the incidence was increasing, but that's because just before we had specialist pathology, it was often wrongly classified as other types of tumours. And I think there's more awareness of GIST nowadays. I think we really see it affecting all age groups, and certainly in our clinics we see patients from 18 to 80 or 90 years of age. And I think it's important to emphasise that the treatment imatinib is generally tolerated well amongst all of those age groups.
You mentioned some side effects of imatinib. Could I just come back to you, Satvinder, and side effects of surgery? Anything, complications that we need to worry about?
Well, I mean, that depends on the specific type of surgery, whether it's going to be surgery to the stomach or the intestine. And I think the group, I think your point is well made, that in the younger patients, if you've carried out major gastrointestinal surgery, whether it's to the stomach or the intestine, but in particular to the foregut, to the stomach, then in a young patient you're going to have problems of the long-term nutritional problems of having either your stomach removed or part of your stomach removed, and that will relate to micronutrients, calcium, iron, bone quality. I mean, these are the things that I think about in my clinics with the younger patients, are those issues of how we're going to manage those patients as they get older and start to develop these problems of vitamin D deficiency, bone thinning, all these things, that they may wish to become pregnant and so on, and they've had major surgery, and all of that's got to be taken into account.
I think it's really important for GPs to have all of this communicated to them, and I think the vehicle that is now mandated as part of the updated cancer strategy with implementation of the recovery package and commissioning of end-of-treatment summaries, when they get to us and to the patients, I think GPs will feel a lot better informed, particularly pertinent to these rare tumours where we've just not come across them. Many of us will not see a patient in our lifetime, although we diagnose cancer fairly more frequently in other tumour sites. I'm interested about the younger woman and the conception and contraception issues. Is it something that when they've moved on to needing, if they've needed to have imatinib, do you counsel them against getting pregnant, or is it something that's safe?
I think we have very little information regarding pregnancy and imatinib, and we usually advise...
You wouldn't do trials on...
Yeah, precisely.
Yes, yeah.
So we'd usually advise people
to contraception.
And to maybe even if they are pregnant, to be off treatment. And
do you know if it affects fertility long term?
Again, we have very little data, very few data to guide us.
So patients can really be left with quite a lot of psychological issues at the end of this. So not only have they may be young and still trying to work and raise a family, they have issues as to worry whether the cancer is going to come back or not. And again, that is something that is really earmarked as a point of work for us as a cancer community to support our patients with the long-term effects of treatments. They might be cured, but at what cost was a Macmillan document that came out a few years ago. Patients locally to you, do they have open access to their CNS? Do they need to come back to their GP and be re-referred? How does your re-entry system work? I know that that's specific to the Marsden, but it might give my GP colleagues some way of sort of questioning what happens in their local pathways.
I think, as Charlotte mentioned, with the clinical nurse specialist, most of the patients would re-enter the system that way by contacting the nurse.
So they have that forever. What are the chances of it coming back?
We do have a way of trying to predict that, and when we're looking at what are the risks of a GIST after surgery, there's some criteria that have been laid out by two pathologists, and we're particularly interested in the size of the GIST, where it's come from in the gastrointestinal tract. As Satvinder said, it's most common in the stomach. If it arises in the small bowel, for instance, that's often a higher risk of coming back. Right. And also with the pathologist, they'll tell us what's the mitotic count. And that will give us an idea of what's the activity of the GIST.
Growing.
Some patients have very low risk GIST, and we know that they're very unlikely to come back. And those are the patients that we can safely discharge back into the community.
And without going into too much detail, very often very small GISTs are discovered coincidentally when somebody undergoes an operation for another type of cancer. And the incidence of those very small tumours may be as much as 30% from post-mortem studies. So there's a spectrum there.
How involved does the GP need to be when the patient is with you on treatment? Do we need to get involved in monitoring blood tests, liver function, renal function, which often happens as a special arrangement with, say, the rheumatology department in us? But do we need to worry about those levels or any other blood counts with our patients?
Most patients on imatinib, we'll do a blood test once every 3 months, and usually that can take place in the hospital. Sometimes we can see blood changes like neutropenia or liver function test changes. They're quite rare, but sometimes we will ask the GP to help us with that, particularly because patients are coming to specialist centres and often don't live that close to our centre. But we like to keep our GP sort of informed about what's happening and request that as needs be.
I agree that clear communication is always important.
It's really critical, and especially in where I come from in Gloucestershire, with such a large geography with rural transport issues and things. So it is important that we work together as a system. Some people I know are have been recruited and consented to take part in the 100,000 Genomes project, and are people worried about a genetic implication? Are their children going to develop GIST tumours?
I think it's important that we can reassure the majority of our patients with GIST that it's not hereditary. There are some very rare syndromes associated with GIST and also neurofibromatosis, but that's something that we would consider looking at the patient's history.
And can you tell on a molecular level whether there is a prognostic indicator that is less favourable?
Well, as understanding of GIST has really increased, we can now look at molecular level and changes in the KIT gene and also the PDGFRA gene, which also can be affected. And looking at molecular changes there can help us to understand the behaviour of the GIST and also sensitivity to treatment.
I think that factors into a question you asked earlier on about specialist centres and the knowledge that we've gained about GIST over the last 20, 25 years has been a result of research, and it's very important that we carry on conducting clinical trials and laboratory research on these tumours. So again, emphasising the point regarding the value of specialist centres.
Special centres and clinical trials as well. Of course, we should be encouraging our patients to take part in trials. So what do you feel are the top 2 take-home messages?
Well, I think from diagnostics it would be think GIST in a patient who has symptoms that are difficult to pin down and you've been trying, think of a rare diagnosis.
Thank you.
And I think the second one is to advocate to your patient for referral to a specialist MDT for in-depth discussion.
So we, as GPs, we don't have direct access into a specialist MDT, but we should be aware that GIST tumours are so rare that actually every patient who is diagnosed with a GIST tumour should be offered to have had a discussion of their management at a specialist MDT. So we could be on the alert to make sure that we receive that sort of paperwork, etc. That's great. Well, thank you all so much for your time.
I hope that wasn't boring. I hope it was interesting. And obviously I'm hoping that everyone here, when we get this loaded up onto our website, will draw it to the attention of their GP. And obviously if we network like that, we'll get the word spread across the country.